Okay, thank you. Great to be here again. Thanks to Professor Siebenrock for, again, another great meeting. So I'm pinch hitting here for John, but this is work we've been doing together for a decade now. So is PAO and borderline justified? So borderline dysplasia, classically defined as lateral center edge 18 to 25, or maybe 20 to 25. We now know this is an oversimplification of a very complex and variable deformity. Decision-making in this population is one of the big controversies in hip preservation, and we really need to think about this globally. Coverage, version, femoral version, soft tissue laxity, previous surgery, all can affect the decision-making. We know the risk of arthritis, at least in females, extends into this borderline range, which makes this a challenging population to decide on arthroscopic treatments versus open treatments like the PAO, and we commonly see patients who have failed arthroscopy in this group. So we have a good understanding of the role of PAO in the dysplastic hip, so we'll hit upon each of these points in the argument. Instability remains a common cause of hip arthroscopy failure. We've seen this in our anchor work. Up to 25% of hips undergoing PAO have now had failed arthroscopy, and many of these failures are in this borderline group where maybe we can get this right from the first time. So here's a typical patient, a 23-year-old female, pain for 4 years. She's had failed previous arthroscopy with sort of a less than ideal treatment, labral resection, releasing her psoas, no capsular repair. Her exam is significant for soft tissue laxity and evidence of continued impingement as well as instability, and she has borderline dysplasia. So I think in this patient, it's maybe not as debatable, but optimal treatment probably includes a PAO, but maybe we could have got this right from the beginning. So here's the findings at the time of arthroscopy, a pretty diseased labrum. I think in many hands in the US, this would get a labral reconstruction, maybe without a PAO. But here a PAO overpowers the residual problems of the psoas, of the labrum, of the capsule, and has an excellent outcome in this patient that's durable now 7 years down the road. Unfortunately, failed hip arthroscopy can compromise our outcomes of PAO. So this is previous work from Eduardo Neves in anchor matched groups, about a 10-point difference in Harris hip at the end stage, depending if you had previous surgery. So it's not as simple as trying a hip arthroscopy and we can save it down the road. The outcomes of PAO are excellent, certainly from work here, as well as our work in WashU, 92% survivorship at 15 years. We see excellent outcomes in terms of activity restriction, so these patients can get back to high level of activities, 93% reporting satisfaction with their level of activity in our study. Here's our survivorship, 10 years, 15 years, and now we're in the process of looking at 20 years, very good and a durable treatment outcome. We now know from work of Cody Wiles at Mayo and others that we have more evidence PAO can alter the natural history of dysplasia. So this is looking at the contralateral hip comparing to those hips that underwent PAO. So this probably not only helps patients in the short term, but also in the long term. So now if we look at hip arthroscopy in borderline, lots of literature on this, but the results are highly variable. The outcomes in general are good in many patients, but there's definitely a subset of patients with suboptimal outcomes. Many of these won't have repeat surgery, but have poor PROs, so in the range of 30 to 40% of patients in these large centers from expert arthroscopists still having suboptimal outcomes. So maybe PAO is the solution. If we look to the literature, small cohorts from several institutions, including Chris Peters' work here, 20 hips, excellent rates of outcome improvement, as well as avoiding subsequent surgery. So how can we decide? Taking a patient-specific approach is really optimal. At WashU, this ends up being probably about 60% arthroscopy, 40% PAO in our current population. Many of these combined PAO with arthroscopy. We've found multiple factors predicting which route we go: acetabular inclination, the anterior center edge angle, internal rotation, and the alpha angle. With these factors, we can really predict the diagnosis in our hands as well as others in anchor. So we did this study looking at a large cohort of our patients in the borderline group undergoing PAO, so 188 hips at a mean of 3 years of follow-up. Not surprising, these are majority female, 88%, mean age of 25, 16% had previous failed hip arthroscopy. So on average, these patients improved significantly. Harris hips in the 85, low rates of reoperation, only 3%. If we look at clinical outcomes, 89% of these patients reach either MCID or PASS for the Harris hip, which is a pretty good bar, I think, compared to other hip preservation surgery. If we break this down by previous surgery, those with previous surgery reach this at 78% rate, while those without previous surgery are reaching this at a 92% rate. So very reliable, consistent outcomes of the PAO in borderline. So this is a typical patient, 23-year-old dancer, borderline dysplasia. We're often using arthroscopy in these cases if there's significant labral disease on the MRI. The reduction in the PAO is gentle, avoiding reduction and creating impingement. And we're looking closely at secondary FAI here because often these patients have a combination of dysplasia and impingement going on. There you can see her radiographs after PAO with a successful outcome. So we can apply this in our high-level athletes. Here's a variety of cases across a number of sports that I don't think athletic activity should be viewed as a reason not to approach this ideally with the best surgery first. So in summary, instability is a common reason for residual symptoms after a hip scope in the borderline group. Scope failures do compromise our ultimate outcomes. PAO outcomes in borderline we've demonstrated to be maybe some of the best outcomes we have in hip preservation surgery, and hopefully this is not only improving symptoms, altering the natural history, getting these athletes back to their sports as well. Thank you.